وسام، ازيك يا كبير؟ الاخبار؟ الحمد لله، اتفضل.
السردانس هو احمد لسه معانا ولا خلاص؟ دكتور احمد لسه معانا ولا خلاص؟ دكتور احمد سامع؟ لا يعني هو قفل خلاص؟ قفل خلاص؟ اوكي اتفضل.
Assalamu alaikum. Good morning. My name is Wesam Mozy. I'm a lecturer of radiologists in Qasr High School for Medicine, Cairo University, and head of the Radiology department in Aswan Health Center. Our talk today will be about the role of cardiac MRI in arrhythmogenic right ventricular cardiomyopathy. We'll discuss the definition of the ARVC according to the European Society of Cardiologists and present and explain our protocols for the ARVC and describe the features in the ARVC. And lastly, we'll discuss the differences between the 2020 international criteria versus the older 2010 task force criteria. The arrhythmogenic right ventricular cardiomyopathy is predominantly inherited as an autosomal dominant disease with incomplete penetrance. The characteristic feature of this disease is fatty or fibrofatty infiltration of the right ventricle. However, recently, as we say, the involvement of the ARVC is not exclusive in the ARVC. It could involve both ventricles or even only the left ventricle. It's one of the most common causes of sudden cardiac death in young adults. This is a picture to show the fatty infiltration of the RV free wall. And here is a leg adrenaline image showing the arrow shows fibrous infiltration of the free wall of the RV. The task force criteria were originally described in 1994, and there was no involvement of the MRI in these criteria. However, in 2010, it was modified, and the MRI had role in this modified criteria. The MRI would give just one criterion according to the task force criteria, either major criterion or minor criterion. The criteria is based on the regional wall motion abnormality in the RV in the form of akinesia, dyskinesia, or dysynchronous contraction, plus one of two, either the dilatation of the RV with specific numbers. In males, it will be for a major criterion to be at least 110 or more milliliter per meter square, and for female it would be 100 or more milliliter per meter square. Or the RV ejection fraction would be 40 or less, 40% or less. If we have the same wall motion abnormality in the form of akinesia, dyskinesia, or dysynchronous contraction, but the dilatation is less than that, meaning that in a male it would be 101 to less than 110, or in the female 90 to 99, it would be a minor criterion, or the ejection fraction would be 41 to 45. This is an example for a patient with ARVC. As you can see, there's a dysynchronous contraction of the and dyskinesia of the RV wall and even the LV wall. The LV is involved in this case. And it is more apparent here in the short axis. It is preferable to judge the wall motion abnormality in two perpendicular planes, not in one. So you have to take a short axis stack and an axial stack. The proposed protocol for case of ARVC would be anatomy and LV function. LV function, we mean short axis SENI stack, and RV function is the axial and RVUT stack. Slice thickness would be between 6 and 8 millimeters without interslice gap to better judge for the wall motion abnormality. And the detection of the fat in these cases is optional. You are not, it's not part of the criteria, not in the task force or even in the international criteria. So you might skip this step. But the leg gadolinium enhancement, it is not in the task force criteria, but however, we used to do the leg gadolinium enhancement because it was of importance in the prognosis of the patient. However, in the international criteria, the 2020 international criteria, it became one of the major criteria for the ARVC. In the report, you should mention the volume and function of both ventricles, LV and RV, and you should describe the RV wall motion abnormality. And there is a triad of dysplasia in the RV. This is the inflow, the outflow, and the apex. The presence of RV abnormalities, whether aneurysm or outpouch, should be mentioned. And if you acquired a fat images, pre and post fat suppression, you should state that. And of course, the presence and extent of fibrosis. According to the task force criteria, the diagnosis of ARVC could not be established based on the imaging alone, because as we say, that we can only extract one criterion from the MRI, either one major or one minor, and to establish a definite diagnosis for ARVC, you should have at least two major criteria. But you may establish a possible diagnosis, because in a possible diagnosis, you only need even one minor criterion. And in the, you should not confuse the moderator band dipping in normal personnel with in RV wall motion abnormality. And you should consider alternative diagnoses like neglected shunt, ASD or VSD in an adult patient that causes RV dilatation. For the international or BADWA criteria, the 2020 international criteria, the term of ARVC was changed into the arrhythmogenic cardiomyopathy, because as we say, it may involve the RV or the RV and the LV or even the LV alone. So the idea of being exclusive to the RV is not there anymore. So the heart muscle disease could affect the RV, the LV, or both. And as we said before, the hallmark of the diagnosis of the pathology is fibrofatty myocardial infiltration, either for the RV or the LV. So they classify to the ACM, the arrhythmogenic cardiomyopathy, into three categories: the dominant right, as we knew before, the ARVC, and the biventricular, which involves both RV and LV, and the dominant left, that is called the arrhythmogenic left ventricular cardiomyopathy. The most important point in the new criteria is the tissue characterization. They included the leg gadolinium enhancement into the new criteria as a major criterion, whether to the RV or to the LV. And they changed a little bit in the morpho-functional criteria. This table illustrates the new criteria. They are categorized in two groups: the morpho-functional, like the old one, the wall motion abnormality and the volume and function. However, the change here that in order to have a criterion in the old criteria, we should have both wall motion abnormality plus dilatation or reduced function. But here you don't have to have dilatation or reduced ejection fraction. Only the wall motion abnormality could mean a minor criteria. And they designed a criteria, new criteria for the LV in the morpho-functional group, but both are minor, either global LV systolic dysfunction or regional LV hypokinesia or akinesia. And the second group was totally new, the structural myocardial abnormalities, meaning that there is myocardial fibrosis, whether in the RV or the LV, it would be a major criteria. So we say that in task force criteria 2010, we can extract just one criterion for the RV, either major criterion or minor criterion. But according to these new criteria, you can have up to 4 criteria. 2 for the RV and 2 for the LV. And these are the differences between the volumes and function parameters between the international criteria and the task force criteria. This is a flow chart describing the new criteria and how to use it to reach a diagnosis, whether you have RV involvement or LV involvement or both. And as you can see here, that we need 2 major or 1 major and 2 minor or 4 minor criteria to reach a definite diagnosis of ARVC or biventricular. And if we have just 1 major and 2 minor or 3 minor, this is a borderline diagnosis. And if we have 2 minor criterion, it means that we have possible ARVC. So according to the task force criteria, we cannot establish even the possible ARVC alone. We can establish the ARVC if we have just 1 major. But in the newer criteria, the international criteria, we can reach a definite diagnosis just from the MRI. In conclusion, the international criteria aim to improve the diagnosis of ACM by providing new criteria for diagnosis of biventricular and arrhythmogenic left ventricular cardiomyopathy. And they are heavily dependent on the MRI. As you can see, both the morpho-functional and the structural abnormalities. And the preliminary data confirm that the clinical use of international criteria substantially impacts the diagnostic accuracy. However, the validity of this new diagnostic approach needs to be assessed by future studies on large patient population. Thank you.
Thank you, Dr. Wesam. For any questions? Okay, we will go to the next speaker, Dr.